welcome, and it's good to have you attend. This is, as we said last month, I think it was. This is an interactive session where I would show you scanned slides from my own collection, discuss the history with you, and then discuss the morphology, and then hope that you would then contribute with the differential diagnoses and suggestions and investigations and assays or immunohistochemistry. So please feel free to join in the conversation, because that's what this conference is all about. It's interactive, and that's the purpose of linking up with Lydia and Diagnexia, is so that we can have this zoomed to a wider audience. Okay, so this case I've just picked up, it's a continuation of the set of slides I had from last month, and this was a lesion on the scalp. It's an occipital scalp, and I'm sure those of you would recognize the epidermis here on this low power view with the adnexal and pilosebaceous units, and then the subcutaneous fat. This blue area here, and I'll just zoom in a little just to show you. This is where the lesion was excised previously. So these are all post-surgical site changes, multinucleated giant cells, and even some foreign material. But that's not what I want to show you, because when they went back to excise this, there was still residual tumor. And these are right at this corner, and you can see it's right at the ink, unfortunately. Like I said, he's 29, occipital scalp, and there was a previous excision as well. So this was, in fact, a re-excision. And unfortunately, it's right at the ink. So, and you would all agree that they then have to go back to get this entire tumor out. But we do have some tumor here to talk about, which is why this got onto the slide set. And I'm going to show you the morphology. Just on low power, you can see it's pretty cellular. It's quite cellular. Let's just go down and look at it. You can see some large pleomorphic cells here, which are quite epithelioid. Here's some that are more epithelioid and plump. Some are spindled as well in the background. I'm just pointing these larger ones to you. And like I said in the past, I do not give any indication as to what it is or what I think it is or what we called it. So I would hope that you would contribute to that conversation. Here we have more plump epithelioid cells, spindle cells. Some have prominent nucleoli as well. Again, just to repeat for those who may have just joined us, this is a young man. He's 29 years old. This is a scalp, which was scalp tumor that was previously excised. This is the other focus that we have of residual tumor. And in it, you can see, again, these large pleomorphic hyperchromatic cells in between this background of spindle cells. Here we go. I'll just show you on high power. Almost like a donut-looking nucleus. Any thoughts? Please feel free to I suppose, communicate with Lydia and talk. I'm not sure whether the channels are open, Lydia.
Yeah, no, they just raised their hand. I will unmute allow them to talk, yeah.
There you go. So tell me what you think. Oh, there's some nice, more epithelial looking cells, background of spindle cells, and this pale eosinophilic cytoplasm, well, pink really, not pale, but quite pink, and no distinct cytoplasmic borders. Any thoughts? Any investigations that you want?
Oh, we have Maria.
Maria Giubiotti, all the way from Texas. Hi, Maria. How are you?
Hi, Dr. Cooper. I miss you.
Oh, I miss you too. This is so good that you've got this link. I'm so happy that you are here.
Yeah, Zubair sent it to me.
Oh, that's wonderful. I'm so happy. This is Maria Giubiotti, who used to be with us. She trained with us, spent 5-6 years with us, and then vanished to Texas.
Yeah. So, I mean, derm and soft tissue are not exactly my expertise, but I'll give it a go.
I know you would. I know. And that's why I'm so happy that you're here, because, you would create this ambience of conversation and people will join in. So,
Well, I'm just I have no shame. I'm not afraid to be wrong.
well,
So I think, this is clearly a cellular lesion. It's a younger guy. I think with those pleomorphic cells, some of them have kind of this vacuolated cytoplasm as well. And some have prominent nucleoli. So if he's 29, I mean, to the scalp, I guess you have to rule out a melanoma because common things being common, and I also, now that I live in Texas, everybody has some kind of weird melanoma here from being out in the sun. But I think you also have to think about different kinds of sarcomas or, with the pleomorphic, almost floret-like or donut-like cells. It could be some kind of pleomorphic sarcoma that probably needs molecular, maybe for definitive diagnosis. The other thing I was thinking, it's less likely a metastasis given his age, but I was thinking like in some of the other areas that you showed, I don't know if I'd do a histiocytic marker maybe, and maybe a vascular marker.
okay, that's a great start. That's a great start. Anybody else have any other contributions or thoughts just to add to that, to broaden that differential diagnosis? There's these large prominent nucleoli. That's pretty large, and Maria very nicely spotted those and brought in melanoma, which you have to. This is quite deep. He is young, but melanoma has to come into that differential. You can see the previous excision. Yeah, I'm just waiting for this to focus. The previous excision, just if you came in late, and this is a residual tumor, which is at the deep edge of the margin, right in this top left-hand corner of the slide. And as you can see, we ink everything, and this is pasted with ink. So they had to go back, and there was a resection as well, which had very little tumor, really, and most of it was out. Now, Maria's mentioned some really, really good differentials, and melanoma certainly has to come into that differential, particularly with those large nuclei, large nucleoli, and very pink cytoplasm. So I will add that the SOX10 and S100 are diffusely positive, However, because Maria mentioned the melanoma markers, we also do the HMB45 and the melin A, and all of those are negative. So PRAME is negative, HMB for MITF, tyrosinase. So the true melanocytic markers are negative. As you know, S100 SOX10 is purely a screening tool for melanoma. So I will give you that the S100 is diffusely positive, so you can sink your teeth into that and tell me what you think. The other differentials that Maria mentioned was sarcoma, some form of spindle and pleomorphic sarcoma would certainly come into that realm now that we've mentioned that S100 and SOX10 are both diffusely positive. And she also, like a true neuropathologist, suggested next-gen sequencing, which neuropathology do routinely for all their tumors. I wish we had that in sarcomas, I really do. But nobody really cares about us. So we left to morphology, immunohistochemistry, and our good old fish. Okay. Histiocytic was mentioned. I'll mention that the histiocytic markers are both negative. So I'm not going to go through the CD68 or CD163 unless you ask me what those are, and we can talk about it. But the histiocytic markers are negative. So we left really with S100, SOX10, diffusely positive, clearly malignant because of the nuclear pleomorphism, excuse me, nuclear, and the depth of invasion as well. And you can see this is behaving pretty aggressively here. There's more sort of residual tumor here. I didn't go into this area, but there's some myxoid matrix here as well. I like to see this gray-blue material to call it myxoid. And again, the nuclear pleomorphism pretty evident here, just on higher power and prominent nucleoli. Now, anybody would like to give me one more stain that they would like to do?
H3K.
H3K, right? So Tom is Doctor Who is was a prominent breast pathologist here in our group, and an excellent cytopathologist as well. He loves sarcomas, and suggested H3K27ME3, and that's a marker for nerve sheath tumors, which typically follow the NF1 pathways, preceded by by mutations in the chromatin remodeling proteins. This more the PRC wing, that's the polycomb repressor complex. The two genes that are typically mutated in the MPNST pathway, NF1 pathway, are EED and SUZ12, SUZ12. You'll recognize SUZ12 from the uterus, right, for endometrial stromal sarcomas. But those are also in that pathway. So Dr. Hu wanted the H3K27ME3, which is only lost when there's a mutation in those genes. There's a loss of these chromatin remodeling proteins, in this case, the trimethylation H3. And so when you do the antibody, it is lost. And that's a positive, quote unquote, positive reaction. So that was intact, Tom. So that's intact, but it doesn't rule out, and the nerve sheath tumor via the NF1 route, because only 60% of them are lost. So there is the 40% that you have to play around with and say, oh, well, could this still be an MPNST? So we're still in that realm. We sort of getting down to nerve sheath tumors because of the S100 SOX10, the absence of the true melanocytic markers. And we're now talking about nerve sheath tumors. We talked about the NF1 pathway. And again, opening it up for any conversation about any other pathways that people have for MPNSTs. MPNST meaning malignant peripheral nerve sheath tumor.
Is there a muscle marker? Like maybe, I don't know if this is a Triton tumor exactly, but
yeah, that's I see my fellow Ahmed Lazim, who's an extremely active sarcoma pathologist, got his arm up. But let me answer Maria's question. The muscle marker would only give you differentiation, and in that context, with the MPNST via the NF1 route, would just make it a Triton tumor. There have been people who've suggested that those have a more aggressive outcome. But the muscle markers were negative in this, Maria, just to get that out. I typically would use a desmin or an actin to screen it. And if that's paused, then, maybe go on to the skeletal muscle markers, because that myoid differentiation in Triton tumors are skeletal muscle. And MyoD1 and MyoGNN are the two markers that we have, excuse me, to rule that out. Now, that's a good point that Maria brings in, because if you thought that this was a muscle tumor, and if you did the muscle markers, some of the MPNSTs can have diffuse myoid differentiation. So be careful of that, particularly in context of where the tumor is coming out of the nerve roots in the paraspinal area. And you think this is nerve sheath, but it's giving me a diffuse muscle marker immunoreactivity. And you say, leiomyosarcoma, be careful, because it could be an MPNST with extensive myoid differentiation. All right, that's not my thoughts. That was Dr. Hornick, and I think it was Dr. Fletcher who described that in AJSP a few years ago. So you can check that paper out. But there's a series that they described had extensive myoid differentiation, and in that context, think of the location, think of the site, and then the marker that Dr. Hu mentioned, which was H3, would be helpful in pushing you back into MPNST. But like I said, MPNST is only lost in about 60% of those via that pathway that I mentioned, PRC, EED, SUZ12, H3K27. See, the hands are coming up quite nicely, and I see Ahmed. Forgive me, Ahmed. I want to introduce you to Carla. Introduce you guys to Carla. Carla and I met in Botswana, and we spent 3 or 4 years together. And then she went off to South Africa to do her senior training. She's completed the South African boards, which is no mean feat. They have a tough examination. 5. It's really, really tough. I don't want to go into the breakdown of it. But Carla completed that. She's now back in Botswana. So, Ahmed, I'd love to hear Carla. What do you say, Carla? Carla Lelo Coronale. Can you hear me? I can't hear you.
Yes, yeah. Hi,
Yes.
Prof. Yeah.
Yeah, I was just waiting. Carla, can you unmute yourself? No? All right. No, she cannot. Right, Ahmed. Tell me what you think, Ahmed.
So what AWS are on fish?
Why did you want that, Ahmed? Ahmed always has to tell me why he wants things. So
Yeah, this floret-like cells, we need to rule out also clear cell sarcoma.
okay, clear cell sarcoma is an excellent thought, but the melanocytic markers should have been positive, right?
It was SOX10 S100, right? Positive?
Yeah, that's all. Yeah.
But
Melanocytic markers are
sorry,
negative.
yeah.
Right? There is a route, there is a way you can get out of that, Ahmed. You can get out of that. Anybody want to get out of support, Ahmed? Any other thoughts? This is getting really into esoterica here, guys. You know, it's getting into a deep conversation here. Anybody want to
So,
bail Ahmed out? How would you
Prof,
bail him out?
yeah, about neuroectodermal tumor also of the GI origin can be negative for
Correct.
HMB for
Right, correct. So you can get extra gastrointestinal neuroectodermal tumors. So it's an extra GI or non-GI, but occurring in soft tissue. There's a nice paper by Dr. Fulp. Again, I think it's modern pathology in the last year or so, extra GI GNETs. And you're absolutely right. So could this be an extra GI GNET? And like Ahmed said, the way to prove that would be to do the EWSR1, which belongs to the FET family, FET. FUS may also be rearranged, I think, in that context. So that's why I mentioned FET. But it's not that, Ahmed. We did something else. Anybody?
myoepithelial markers?
Myepithelial markers, epithelial, myepithelial, all negative.
Negative.
Negative, yeah. That's a good thought, thinking, could this be myepithelial as well?
Can I throw in CD68 and an inhibin?
Yeah, Maria mentioned that, Giubiotti mentioned that earlier, histiocytic markers, and I told her the histiocytic markers were negative. Some of them do look granular cell. Yeah, showing you some of this more pleomorphism and large cells, prominent nucleoli. What were you thinking, Tom? Something like a one of those weird dendritic cell tumors?
No, well,
Dendritic cell.
no. So granular cell tumors rarely can be malignant, and some of the features would include tumor cell spindling.
Right.
And so, albeit rare,
Right.
on the differential.
Okay. Thank you.
But
Okay,
still, the Prof, desmoplastic melanoma can be negative for melanoma. Still,
That's
SOX10
true.
and S100.
That's very true. Can it have this degree of nuclear pleomorphism? I don't know. I'm asking. And he's very young, Ahmed. He's very young. He's
Yeah,
29. Those are more elderly patients. And remember, those are typically dermal or epidermal based, right? Oh, come on, focus. Okay,
yeah, and fibroblast-like
right. So
morphology.
this is pretty deeper. So the desmoplastic, typically dermal, subcutaneous. You want lymphoid tissue. You want necrosis, and but yeah, that's a good thought. Very good thought. Any other thought? There was one other stain I was encouraging, because I gave you a clue there. I said that the pathway that Tom Hu talked about, and continuing from Maria's conversation and Ahmed, was the MPNST via the NF1 route, via the chromatin remodeling proteins, the so-called PRC, or polycomb repressor complex. There's another route as well with these more epithelioid cells, plump epithelioid pink cells, INI1, SMARCB1 deficient. This was lost for SMARCB1. So we were able to call it an epithelioid MPNST, which does not go via the PRC route. So H3 is not helpful. H3 is intact. In fact, H3 was intact in this. So, okay, that was a great conversation there, guys. Any comments or questions that anybody has? Okay, now I'll move on to the next case then. Thanks for that interaction conversation. Let's see, 694. Let's try this one. Let's try. Oh, I've got 2 slides. So that's a treat. That's a treat. So this is a 70-year-old male, and he had a left hydrocele. So they went in there and well, whatever you do with hydrocele surgically, that's what they did. And this is what we received. So a lot of connective tissue, right? This has been serially sectioned, right? Because of the hydrocele, so they sectioned it. Not sure if they saw these grossly. I really should be looking at the gross to be able to tell you whether they saw this grossly. But here you can see this pretty much blue structures here. Here we go. There and here as well. Okay, I'll give you a peek into them. All right, let's go to the first one. And you can see these closely opposed to the base of this area. Pretty blue. High power. This is slightly thick or maybe overstained. Let's find one that is a little more cytologically evident. There we go. Nice. Nice. And any thoughts you have or any stains that you want, just unmute and holler yourselves or raise your hand and Lydia will unmute you. Okay, so just to repeat that history, 70 male left hydrocele.
Hi, Prof. Thanks for the earlier introduction. I would like some mesothelial markers.
Okay.
Yeah.
Yeah, the mesothelial markers are all positive, Carla. Nice to hear you again. Nice to hear you. So Carla was there. I was worried that Carla got cut off.
No, my connection is a bit shaky. Sorry about that.
Yeah, no, I know. The Botswana, the bandwidth always sometimes does give us problems. But I'm very happy to have you on. So the mesothelial markers are all positive, and then that sets off the question of what do we call this? It's papillary. You have papillary excrescences, and you can see that it is arising from a mesothelial line surface, which I was showing you earlier. You can see that. So
I think there was some discussion or change in terminology of not calling it a malignancy, rather just a neoplasm with this papillary architecture and not much of like pleomorphism. I'm not quite sure was it well differentiated papillary?
yeah, that's correct. That's correct. You were well taught, Carla. Carla was in Western Cape, and they see a lot of mesotheliomas there. And historically, if I can just mention the northwest part of the Southern African country, it's called the Priska Kuruman area, and there were a lot of mesothelial mines there, asbestos mines, I beg your pardon, asbestos mines in that area. And so they saw a lot of mesotheliomas. And so we still see that from the previous eras, and there's still a lot of mesothelioma. So Carla is suggesting a mesothelioma, and she's putting it into the papillary mesothelioma category, which is now changed. And if you look at the WHO, it's now called tumor. She's absolutely correct. Now, those are called well-differentiated papillary mesothelial tumors, right? Not mesothelioma, but mesothelial tumors. Those are usually well circumscribed. They're usually about 1 to 2 centimeters, very well differentiated. This would, you could take a picture of this and put it into a book and say, this is a well differentiated mesothelial tumor. Nobody will question you. Uniform looking, cuboidal-like cell, very uniform nuclei. And with this papillary architecture, you could very easily sell this as a well differentiated papillary mesothelial tumor. They typically occur in the pleura. You can get them in the abdomen, but more commonly in the pleura. And those are very well circumscribed. So in radiology, Carla, you'll see a well circumscribed mass. This, in converse or in turn, is in the hydrocele sac. So it's paratesticular. It's not in any of those two sites. And it's, let's go back on low power. It's multifocal. There's a spot there. There's a smaller one here. Okay. There's a smaller one there. And then here, the other areas, you're also getting the same process. So it is multifocal papillary mesothelial. And the question is, what are we going to call it, right? The well-differentiated one is usually a well-circumscribed mass. This is sort of multifocal.
Multifocality reported in those tumors.
No, they're not. For those particular tumors, no, they're not. So the well-differentiated papillary mesothelial tumor is by definition a single mass, well circumscribed. And they do very well, and that's why they took away mesothelioma and they call it tumors. And the WHO now calls them tumors instead of mesos. So those are clearly morphologically and geographically here as well distinct. So this in turn is in the hydrocele, multifocal, and you have all these papillary excrescences all over the place. So it is well differentiated because they're pretty uniform. Some of you may be asking, well, could this be mesothelioma in situ? And that's an entity that was first described in Australia many years ago in the 90s. Nobody believed them, but mesothelioma in situ can also be papillary. And there's one marker that you can use to confirm a mesothelioma in situ. Anybody want to tell me what that is?
Desmond?
Carla's mentioned all the mesothelial markers, so that by that definitionally, I think calretinin, D240, WT1, CK56. That's my panel of 4 mesothelial markers. There's one other marker that I use now, currently, last couple of years, to add to that. Ahmed's just mentioned Desmond, which is a very, very, very old marker, where in the late 80s, the early 90s, people used to say that Desmond was positive in mesothelioma, but negative in hyperplasia. But that's gone out now. Nobody really uses Desmond in that context. But I suppose it's still in the books and it's still historical. But I was thinking of BAP1, BRCA-associated protein, and that's lost in a subset of mesothelial malignancies by I think it's about 60%, again, similar to H3 we just talked about. So it's lost in about 60% BAP1. There is another marker, MTAP, which we don't have, so I can't comment on that. But BAP1 works very well in our hands and was lost in this as well, Carla. So BAP1 is useful, which told us this is mesothelial, this is mesothelial neoplasm. The question is, what do we call it, right? Because we had these papillary excrescences, so we can make up papillary mesothelioma, but well, you know, how do we go from there? And there's one other feature I want to show you just to help. You can see some of these budding down here, and I saw it in the other slide, but I'm going to go back to the first slide and just show you. Yeah, I think there was one here that yeah, you can see these islands of cells budding down and falling off, right? And there were some that were deeper down as well, which I'll have to find, but there was invasion, and confirmed that I went to my colleague, who's an excellent mesothelial pathologist, Dr. Deshpande, and he said, yep, that's invasion. So the question is, what do we call this? And there's a small series that was described in the mid-teen. By the mid-teens, I mean 2015, 2016, in AJSP, that they called a multifocal mesothelial mesothelioma, multifocal papillary mesothelioma with microscopic invasion. And they do very well, as long as you cut it all out, and they do very well. So there is a nice paper to put this into, and that's in the literature. And you know, we found that paper useful, and that's what we called it. We called it a well-differentiated papillary mesothelioma with microscopic invasion. Remember, Carla, the well-differentiated mesothelial tumor, papillary mesothelium, does not have invasion, right? Does not have. This had invasion, and this was multifocal, and this is in the paratesticular areas as well. So there are 3 reasons why it's not a well-differentiated papillary mesothelial tumor, but instead a multifocal papillary mesothelioma with microinvasion. And like I said, there were other areas where it showed this microinvasion, not everywhere. So that's what we called it. Does anybody have MTAP with them? And if they could comment and tell us how it works. And
We do.
yeah, you guys got everything in Texas, don't you?
Well, I have to say, I've validated a couple different stains over the past year, but MTAP was here before I got here because my colleague validated it. You have to be careful. It's a little tricky. We have a new antibody now that's actually quite good and easy to interpret, but the one that we had before was very weak. But like when it's lost, it's lost. It's pretty negative. Some
So,
people use P16. I think UCSF uses P16 as well, but I don't find that as helpful.
okay, no, that's very interesting. So MTAP is also lost then in mesothelioma.
Oh, in mesothelioma specifically, I use it more for a surrogate for CDKN2A or 2B loss in my gliomas or meningiomas.
Oh, okay,
But
okay.
I assume the same principle would work.
Okay. No, that's why I didn't know any. I've only read about it, and it's a cytoplasmic marker, correct?
Correct.
Yeah. Okay. Oh, that's good. That's very useful. Any other questions or comments anybody has? All right. Everybody's quiet and silent. That means everybody's happy, which is good. Yeah, let's try this one here. 26525, I think. 26525, 26. There we go. Okay, let's try this one. I'm now jumping to head and neck, ENT, head and neck. And this was a tumor in the sphenoid sinus, close to where you live, Maria, in the sphenoid sinus.
My two favorite things. Head and neck and possibly pituitary, depending on what this looks like.
There you go. Lovely. So pretty cellular pink. And here, this is a little squashed. Oh, it's not too bad. It's not too bad. There we go. Just to give you some insight into that morphology.
Can you go a little closer there?
Yeah, absolutely. Let's do that. There's some nice vascular changes, the so-called staghorn vasculature. Again, I'm not putting that in there to dissuade you into something else. But here you can see the cell type here.
I mean, depending on what the imaging looked like,
Yeah.
I think you'd still have to do, like, I would do the pituitary transcription factor stains. They have an awful lot of granular looking cytoplasm,
Mhm.
eosinophilic to granular.
Does it point to any particular pituitary tumors or, the subtypes or?
I mean, truthfully, now that we've moved away, like in theory, yes, you have like your acidophils, your basophils, and then your amphiphilic ones. But the other thing that's kind of interesting here is the nuclei, I think. Do they have that like stippled chromatin or no? They kind of have, some of them have prominent nucleoli.
They do.
The other thing that's kind of weird, if you zoom out a little bit, they almost look nested and kind of cleared out, some of them.
Right.
You wonder about a metastasis. How old is this person?
This person is, I didn't give you that, 28, female.
Okay, so probably less likely that, I don't know. I mean, I still think it's probably pituitary, but I was thinking about like maybe, I guess you have to rule out melanoma and weird things or like a renal cell type situation.
Yeah, renal cell is a good thought. That's a very good thought. Yeah, I like that renal cell.
There's also this sinonasal tumor that's renal cell-like. I just saw one of those recently.
Oh, you did?
I did.
All these weird things in Texas. Oh, God.
Those apparently are Pax8 negative, though, which is helpful.
Yeah, they haven't characterized them further, have they?
That I do not
No,
know.
okay. Any other thoughts, anybody? Maria's given us a good headway into this tumor, right? So pink cells, some of them looking a little granular. The nested pattern she mentioned, and nuclei large, some of them having nucleoli. So when I was trying to find areas that show, I suppose, yeah, you can see a nucleolus here, the eye of faith. It either doesn't scan well or there are nucleoli, so you have to believe me, there are nucleoli here.
So, Prof, alveolar soft part and picoma.
Alveolar soft part and picoma. Why did I know you were going to give me that differential, Ahmed? Alveolar soft part and picoma. So Any other thoughts, anybody, before we talk about Ahmed's suggestions?
I
Okay.
like the alveolar soft part idea as well.
Okay. Yeah, I think you have to keep it with PICOMA, Maria, because both of them can be TFE3 rearranged and positive with immunonuclear staining, which this was. This was TFE3 diffuse and strong. Anything less than diffuse or strong with TFE3, just ignore. Patchy, focal, just ignore. It's got to be diffuse, got to be strong. Then you're dealing with a TFE3 rearranged tumor, and you can confirm that with a FISH analysis, and that would again give you the fusion, not the fusion partner, but at least give you the rearrangement, which this is TFE3 rearranged both by antibody as well as by FISH. And then embarking on Ahmed and Maria's conversations, is this a PICOMA or is this an alveolar soft part sarcoma? You can do one of two things. You can either try and determine what the fusion partner is, and Tom had a beautiful PICOMA recently diagnosed on cytology, which was really amazing. And they eventually even sequenced the partner there. And that turned out to be a PICOMA because the partner was a PICOMA partner. For alveolar soft part sarcoma, the TFE3 partner is alveolar soft part sarcoma gene, right? So this, in fact, is an alveolar soft part sarcoma that metastasized to the sphenoid sinus in this very unfortunate 28-year-old woman. And like Maria, you heard, with the differential diagnosis of pituitary tumors, metastatic renal cell carcinoma, and then PICOMA and alveolar soft part sarcoma. That's the classic. And the other one I would mention would be paraganglioma, and you can easily, rule that out with neuroendocrine markers and S100 as well. So you can get the paraganglioma out of the way, you can get the renal cell carcinoma out of the way with PAX8 and epithelial markers. Remember that these tumors can have a little bit of desmond, so don't be startled by that. But TFE3 is the main answer. And then, of course, your PICOMA, you're going to resort to your melanocytic markers, which we talked about earlier, in order to confirm that. PICOMA is a small subset, do have TFE3 rearrangement. And some people claim that they had less muscle, I think it was, in the early days, and they tend to be a little more clear. But the majority of PICOMAs have TSC1 or TSC2 mutations. So that's the other way of doing it. Any questions or comments? Nice case, some pleomorphism here as well. Okay. All right, let's do something a little more common in our practice, at least. This is an abdominal mass, 5 centimeters, in a 58-year-old female woman. So I'm hoping there's some younger residents in the audience who might want to have a go at this. So clearly you can see the fat cells. So then, all right, there's fat cells, and then there's these pink areas. All right, again, I try not to give you any clues, but I'll go down and show you these pink areas so you can see what the cells look like, and then move away from there and go back to these fat cells. And even in this areas, you can see the similar cytomorphology here. You can look at these large nuclei here. There's a large nucleus lining a fat cell there too. Any thoughts, anybody? Like I said, it's a nice, just straightforward case that got into the slide set, but it's always nice to put in classic things as well. Not everything is tough and difficult. Okay, here we go. There's some fat cells that have these hyperchromatic large cells. They're these spindled atypical cells in this sort of sclerotic background. and there's atypia in the fat cells as well. So you don't need lipoblasts. You don't have to find lipoblasts. Just the atypia alone is enough for the diagnosis. Now, the interesting aspect, if you don't know the concepts, would be that if this was in the extremity, if this was in the thigh or calf or arm, we will call this an ALT, atypical lipomatous tumor. Okay. However, this is in the abdomen, and because these are more difficult to excise in the abdomen, we call them well-differentiated liposarcomas. Ahmed and I were looking the other day at the vessels, the books. When you look at the books, they talk about these atypical cells involving the vessels. And when you look for atypical cells, you look at the stroma, that's where you find them. But if you look at the vessels, you can find these atypical guys. Some of these may be endothelial, some of them may be atypical cells, but it's just a novel thing just to talk about, really, when you go and find that. Here's more hypochromasia. So again, just a nice, well-differentiated liposarcoma, sclerosing type, hypochromatic nucleus. Any comments, questions on that? No de-differentiation. This is a curiosity, 27172. Let's see what we have there.
Hi, Prof. Cooper.
Hello, Florence. How are you?
Hi, I'm good.
Are you still in Kenya?
In Kenya? Yeah, I'm still here.
Nice to hear you. Nice to hear you.
Thank you.
Yeah. How long more do you have in Kenya?
Few more months to go,
Okay.
maybe like 9 months or so.
Okay.
Yeah.
All right. So Florence is the chief resident in Botswana, and after
Not
2 years,
anymore.
she left us all and went to Kenya to finish her senior training. So it's lovely to hear you, Florence. Nice to hear you. Now, why
Thank
is
you,
the
Prof.
tumor coming up here? I don't know. Let me try another one.
So Prof. Cooper, I have a question.
Yeah.
So this sclerotic collagen also made me think of the ropey collagen of the spindle cell lipoma, the pleomorphic lipoma.
Correct.
So now in that case, it's kind of tricky for me to differentiate morphologically the pleomorphic lipoma from the sclerotic well-differentiated liposarcoma.
Understood. I'm just trying to get my there we go. We're back online. Somehow my thing went a little wobbly here. So let me get the tumor out here for you. Here it is here. And I'm glad you asked that question, Florence Norris. How is your uncle doing?
He's fine.
He's fine. Her uncle is the vice chancellor at the University of Botswana. So Florence mentioned the ropey collagen, which is a good thought. Now, typically ropey collagen is a little like this, a little more thicker. So that's a good thought, right? And that's what ropey collagen means. The spindle cells would fit with the ropey collagen into a spindle cell lipoma, and those usually occur in the head and neck area. So the dermatopathologists like to call that the shawl area. When you wear a shawl at night, the women wear a shawl. So that's the head and neck, back and shoulders. That's the distribution of spindle cell lipomas. Now, the key feature in that, Florence, is that you do not get atypia. If you have any atypia, then it is not a spindle cell lipoma, even if it's in that distribution site or anywhere else. So this has atypia. This is in the abdomen. So the site is wrong. Plus, we have some pretty ugly looking nuclei. There we go. This hyperchromatic nuclei. You will not get this in spindle cell lipoma. Okay. So let's back up a little bit, because that's a very good question you bring up there. And that's why I encourage people to bring questions. Otherwise, this case now, we're just moving on to the next case. But Florence has got us talking about this concept of spindle cell lipoma, and with atypia, it is not a spindle cell lipoma. So if I took this very same tumor, put it at the back of the neck, and if I saw this atypia, I will say this is not spindle cell lipoma. Even though, like we showed, those nice little some ropey collagen here. You get some ropey collagen. They tend to be a little thicker, but nevertheless, I do like your question, I do. But the atypia, the fact that you have atypia takes it out of the spindle cell lipoma. Now, the next question then you'd be asking Florence in Kenya, Nairobi, Kenya, is if you saw this now in your practice out there, you would say this is not a spindle cell lipoma. Even if you did the RB1, which is lost, it's not discriminatory. Some of them are S100 positive, and typically the spindle cells are CD34. None of those are discriminatory from a well-differentiated liposarcoma. So the atypia, the morphology tells you this is not spindle cell lipoma. Your next step then is to ask, well, what is it? And your first question would be, could this be an atypical lipomatous tumor? Now, remember earlier I said the well-differentiated liposarcomas in the extremity, we call them atypical lipomatous tumor. I'll abbreviate that as ALT, okay? So we call them ALTs, and to confirm that diagnosis, you have to prove something, and the proof is in the amplification of chromosome 12, which is a giant ring chromosome, and if you have an antibody, you can show that overexpression of MDM2 in the nucleus, in the atypical nuclei. Or if you have FISH, you can show an amplification, lots and lots of genes in the nucleus. So either one that you may have will help you confirm that this would be an ALT and not a spindle cell lipoma. Because it's accessible to the surgeon, it's in the extremity, and if they can cut it all out and watch and follow up, we call them ALTs and not well-differentiated liposarcoma. This we call well-differentiated liposarcoma because it's in the abdomen. It's the same tumor as ALT, the same molecular, same immunohistochemistry, and the same morphology. They are indistinguishable, but purely by the location, we call it ALT in the extremity because all you have to do is follow them up. They do recur, some of them do recur, and you cut them out again. And that's what life of an ALT is all about. It never metastasizes until it de-differentiates. When it de-differentiates, then it becomes a truly malignant neoplasm because it can metastasize. And that's when radiation and chemotherapy come into the management pool. Up until then, the ALTs are pure surgical management, okay? So that's why ALT versus spindle cell lipoma is very useful to look at the morphology, and that's how you're going to distinguish it. Does that make sense, Florence?
Yes, thank you, Prof.
Okay, any other questions related to that? Yeah, you can see the atypia here, so that immediately tells you this is not spindle cell lipoma. Now, life is always not that easy, is it, Florence? Because there's another tumor in between that I did not mention because I did not want to confuse the conversation or the discussion, but I have to mention it because if you go and read about it, you say, he didn't talk about that. There is an entity known as atypical spindle cell lipomatous tumor, right? Think about that. Florence mentioned spindle cell lipoma, entirely benign, head and neck, subcutaneous, middle-aged, bland-looking spindle cells, ropey collagen, sometimes some myxoid stroma. In contrast to ALT, atypical lipomatous tumor, aka otherwise known as well-differentiated liposarcoma, MDM2 amplified, right? Those are the two ends of that spectrum. In between now, I'm introducing you to another tumor known as atypical spindle cell lipomatous tumor. I know it's very confusing. I know it is, but it's thought to be the atypical counterpart of spindle cell lipoma, but is MDM2 negative. All right. So MDM2 would still be useful there. And if it is negative, then you can call it an atypical spindle cell lipomatous tumor. They typically have two components. They have a stromal component that's usually sclerosing or myxoid, alternating with areas of fat as well. And you can get atypia in that as well. And the first thing you want to do there is rule out ALT, atypical lipomatous tumor. And if that is negative with MDM2, then you're down the pathway of atypical spindle cell lipomatous tumor. They rarely recur. They do not differentiate for all intent and purposes and for conversation purposes, but the ALT can de-differentiate. The atypical spindle cell lipomatous tumor does not de-differentiate, is MDM2 negative, has atypia, and is not a spindle cell lipoma. I hope I've not confused you. I hope I have not. And please ask questions to repeat anything and we can talk about that. These are all just concepts that we see these routinely in our daily sign-outs, and that would be my approach to it. Okay, Florence, I added another tumor there for you. There's a nice paper by Dr. Fletcher. Enrique is the first author. It's an AJSP. It's around 2017, 2018. And they had something like 235 cases. So it's a nice paper with lots of pictures on atypical spindle cell lipomatous tumor. Now, did we just introduce that in 2017? The answer is no. Because if you go back to the mid-90s, now I'm going to the last century, right? In the late 90s, mid-90s, there was a tumor described, again by Dr. Fletcher, as spindle cell liposarcoma. That evolved over the years, the last 20 years. Over the years, there's about 3 or 4 papers with the evolution of spindle cell liposarcoma to atypical spindle cell lipomatous tumor, which is in the WHO today, that we now recognize, aka spindle cell liposarcoma. There's no spindle cell liposarcoma anymore. All right. And that's how we look at it, because they don't recur that much. There's only about, from my recollection of that paper, is about 12% recurrence. So it's much, much less than ALT, atypical lipomatous tumor, MDM2 amplified WDLS, well-differentiated liposarcoma, which can recur and can de-differentiate. So that's a nice paper to look at. And just look at all the pictures and you'll see the heterogeneity of the morphology, because no two tumors look alike, but it's the atypia that makes you think, this is not spindle cell lipoma. Could it be ALT? Rule out ALT with MDM2. That's the only way you can rule out ALT, is to do an MDM2, either antibody or FISH, I'm afraid. So that's how and it's a big differential, because ALT can de-differentiate, whereas atypical spindle cell lipomatous tumor does not. In that 235 cases that Dr. Fletcher described, there were 2 that they said did de-differentiate. But like I said, for all intents and purposes in our conversation, they do not de-differentiate. All right. Any other wow, we're getting on in time there. Maybe able to squeeze another case. Lydia, we'll see. The other, something else came to mind that yeah, there was a series of, and I'm trying to think who the authors are. There's a series of cases recently in the last 6 months. And again, I'm not sure if it's Modern Path or AJSP, where they describe that the atypical lipomatous tumors can undergo a malignant change. So that's in the making, and I don't want to confuse you. I just tried to give you the concepts. Just ignore that paper for now. All right, we'll just ignore it. Don't confuse the picture. Just keep that approach that we talked about. Any questions or comments on anything that we've talked about? I'll show you this last case because I put it in. It's in the slide set actually. And this is a mandible, right mandible, 77 male. Why am I showing a right mandible 77 male? And I'll show it to you and I'll tell you all about it. It's 1:56 and Lydia is going to tell me the time is going to be up in a few minutes. So I'm going to show you this mandible, which we get from the ENT surgeons. And you can see it's necrotic. This is bone and there are no nuclei. So there's osteonecrosis and there's acute inflammation. And I know Ahmed knows the diagnosis here, but there's acute osteomyelitis, right? There's inflammation, erosion, beautiful erosion here, beautiful erosion. And there's some granulation tissue as well, right? So there's acute osteomyelitis, but there's something else as well. And here's my big blue dots here. And Ahmed and I were talking about this past week with Casey, our medical student who joined us here. In between the bone, you can see some squamous epithelium, right? Squamous epithelium. Here again, this is not detached float. This is part of the dead bone. Here we go. Let me just back up a little bit, just a little bit. Here you go. You can see the squamous epithelium here, in between, insinuated between the bone. Now, your first impression, particularly those who do head and neck, would say, could this be squamous cell carcinoma invading the bone? And that's why the bone is looking so bad. And the answer is no, this is not. This is just hyperplastic reactive squamous epithelium that's dipping down into inflammatory or necrotic bone. These come from the gum and then dip down whenever there's inflammation with reaction of the epithelium. They can invaginate. And that was pointed out by Dr. Andrew Rosenberg, who's in University of Miami. There's a nice paper. Again, I can never keep my times right, but if you go Andrew Rosenberg, hyperplastic squamous epithelium of the jaw or pseudoneoplasia, this will come up. So don't call these squamous cell carcinoma. So I just threw that in as a bonus just to show and tell. And Ahmed had about 2 cases this week with a similar phenomenon that we saw. All right, so not all of this is squamous cell carcinoma. And if you're unsure, then ask the surgeon, is there any mass there? Are you worried about squamous cell carcinoma? And they will tell you, nope, I'm not worried about it. This is purely osteonecrosis of the jaw. Okay, and remember that osteonecrosis of jaw typically occurs in patients who receive bisphosphonates, which is given to build bone in patients with multiple myeloma, but they cause these erosions on the base of the gum and cause infection, and they can then cause acute osteomyelitis and osteonecrosis. Any questions or comments? I know the time is up now, so I'll take a question or two if there is. Otherwise, I'll ask Lydia to sign us out. Thank you all for coming on board. And the next one I should add is April 9th, same time, same place. We'll continue the conversation. I wish you can all join us. And tell your friends there's no restriction, and just have to register with Lydia on Diagnexia and you'll get the link and you can share it with your friends. Okay.